morning, everyone, and welcome to today's Public Health Ontario Rounds presentation on surveillance and testing for the 2024-25 respiratory season. This is the first part of a two-part series with a presentation on respiratory virus vaccines taking place next week. My name is Richard Mather. I'm a public health physician at Public Health Ontario, and I have the pleasure of moderating today's session. Before we begin, I will mention a few housekeeping items. Firstly, I'd like to say that as the moderator of this session, I have no conflicts of interest to declare. The chat pod is being disabled to limit any distractions during the presentation. Please use the Q&A pod if you have questions during the session. A discussion and question period will follow the presentation. If at any point during the session you experience technical issues, please email capacitybuilding@oahpp.ca. I would now like to start with the land acknowledgements. We are fortunate to have people attending today from across Ontario, but this PHO Rounds presentation is hosted virtually from Toronto. Toronto is situated on treaty land, and I acknowledge and respect the traditional and ancestral territories of the First Nations, Inuit, and Métis peoples whose land we are hosted on today. I acknowledge that we are on lands of the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat. I am thankful for the enduring hospitality of the peoples across Turtle Island that allow us to live and work today. I stand with all Indigenous people, past and present, in promoting the wise stewardship of the land, sky, and water of Ontario since time immemorial. It is now my pleasure to present our speakers for today's event, Michael Whelan and Dr. Man Masser. Michael Whelan is an epidemiologist lead on the communicable diseases team at Public Health Ontario. His portfolio includes influenza and emerging respiratory viruses, tuberculosis, legionellosis, and invasive group A streptococcal disease. Mike completed his master's in epidemiology at Queen's University. Man Hasso is a medical microbiologist at Public Health Ontario and leads the viral detection and molecular diagnostic portfolio. He completed his medical degree, as well as a master's degree in medical microbiology from Baghdad University in Iraq. In 2020, he graduated from the Medical Microbiology Residency and Fellowship Program in the Department of Laboratory and Pathobiology at the University of Toronto, completed the Certificate in Medical Microbiology from the Royal College of Physicians and Surgeons of Canada. I will now pass things over to Michael to begin.
Thank you, Dr. Mather. So the learning objectives for this session, as posted in the invitation, are that by the end of the session, participants will be able to summarize current epidemiologic trends in influenza, COVID-19, and respiratory syncytial virus in Ontario, Canada, and internationally, to be able to identify where on PHO's website resources for monitoring respiratory virus activity in Ontario can be found. Describe provincial reporting and entry requirements for the 2024-25 surveillance period. And describe testing options available in Ontario for flu, COVID-19, and RSV for the 2024-25 season. So to do this, the outline of the presentation is that we'll be covering COVID, flu, and RSV activity in Ontario, Canada, and internationally for the 2023-24 surveillance period. Then we'll discuss some considerations for the 2024-25 surveillance period, followed by updates on PHO surveillance products for this upcoming season, before passing it over to Mon for updates on COVID-19 and seasonal respiratory virus testing for 2024-25. So starting off with respiratory virus activity in Ontario and Canada, just to get, before we jump into the graphs, we'll be covering slides that have comparisons to previous periods, but the focus is on 2023-24, and focusing on percent positivity in the lab testing data. For simplicity's sake, PHO does monitor other indicators, including outbreaks in institutions and public hospitals, bed occupancy data from hospitals, COVID-19 deaths too. The hospital bed census data and COVID-19 deaths data can be considered lagging indicators of activity. And some general comments on the graphs in advance. So COVID-19 hasn't fallen into a predictable seasonal pattern as of yet. Influenza activity last season in 2023-24 did follow a pattern similar to pre-pandemic seasons, but RSV activity followed a pattern that was early compared to pre-pandemic seasons, and we'll see these in the upcoming graphs. So the first graph is looking at COVID-19 activity. Tests are in the yellow bars, and the percent positivity is the dark line. Data presented go from August 28th, 2022 to August 25th, 2024. So from the leftmost part of the graph, you can see the number of tests that have been performed has declined over time. However, they do tend to increase when there's increasing COVID-19 activity. Starting last season in 2022-23, there were peaks in late October, followed by a decline and then a second peak in late December. After that, there was a long, drawn-out period of decline, which hit a bottom in late June. Starting late June in 2023, COVID-19 activity began increasing, and with some fluctuation week to week, kept increasing until a peak that happened around mid-November. Following that peak, there was a decline in activity towards the end of March in 2024. Since that point in time, there's actually been increasing activity of COVID-19 with some week-to-week fluctuation. So as opposed to, say, multiple waves of activity, the percent positivity data for last surveillance period, 2023-24, showed one main peak and then a build up towards a peak that hasn't yet occurred and would happen in this potentially 2024-25 surveillance season. Moving on to influenza, the 2023-24 flu season did mark a return to normal. This graph presents influenza tests in the yellow-orange bars, as well as percent positivity in the dark line. These data are from the respiratory virus detection surveillance system that Public Health Agency of Canada runs. It includes data from Public Health Ontario laboratories, as well as 8 hospital laboratories. You'll see an increase in testing, sort of a step change between the 2021-22 season and 2022-23 season. That was due to the addition of some hospitals to the reporting system. So moving from left to right on the graph, in 2019-2020, you can see sort of more of a typical flu season. Peak of activity happened in early January. In that year, there was H1 dominance in terms of influenza A subtype. In 2020 and 2021, there was little to no activity. And in 2021-22, there wasn't really any activity until the sort of late spring, with activity peaking in May, which was quite late for flu, and that was dominated by H3 as the subtype. 2022-23 was the season when we had quite an early start to the flu season, dominated by H3 with a peak in late November. And then last season, 2023-24, the start of flu activity happened a little bit more when we would expect, and peaked in late December, which is closer to when we would expect it to peak. It was mainly H1 activity in the province. However, H3 did co-circulate. And just to give a picture of what the prior seasons or pre-pandemic seasons look like, we'll move to this graph, which looks at 2023-24 and 2022-23 compared to the 5 pre-pandemic seasons. So all of these lines are percent positivity. Starting from the left-hand side of the orange line is the 2022-23 season, and you can see how much earlier it was than the pre-pandemic seasons with that early peak in November. Uh, the yellow line is the 2023-24 season, and so you can see with that it lands more within when other seasons were having increased activity or having peaks closer to when their peaks were. So it was more typical in that season. Um, that's not to say that all the time the peaks happen sort of in that end of December, January, early February time period. There's examples of them happening later for influenza A activity. And the gray line you can see to the 2015-16 season was actually quite a late peak in which happened in March of that season. So influenza B typically happens after influenza A activity has started to die down. And in 2023-24, that was no different. You can see in this graph in the orange line the influenza A activity increasing in November, peaking in December, whereas the influenza B activity didn't really start increasing until into January, February of 2024 before it peaked. At that point in time, flu A activity had already declined substantially, although was still present. So this graph is sort of a way to look at when the pre-pandemic influenza B seasons were occurring, and you can see they move around quite a bit also. Last year, the peak ended in the sort of happened more around typical time for when you would have lots of flu B activity. So it wasn't really out of the ordinary, but you can see in some seasons flu B activity can increase earlier and peak earlier. For example, in the pink line, the 2017-2018 season, flu B activity increased quite early in December and then peaked more January, February time period. So RSV activity in Ontario in the 23-24 season peaked in November. You can see this in the yellow line showing the percent positivity starting to increase uh, earlier than in the pre-pandemic seasons, and then peaking in early November. You can see that that peak is before when most of the pre-pandemic seasons were peaking. For 2022-23, activity increased early. It stayed elevated for longer than it did in the 2023-24 season, with this sort of final peak activity happening more towards the end of December before declining. So the past two seasons for RSV, we've had early activity and earlier peaks compared to pre-pandemic. So what did respiratory virus activity look like for Canada as a whole? Well, overall, COVID-19 activity had peaks in October for Canada, and then remained elevated before declining from December until late April based on test percent positivity. However, those sort of October peaks were a bit earlier than the peak for Ontario, which happened in mid-November. For influenza A test percent positivity, that increased through November and peaked at the end of December, which was the same timing as happened for Ontario. And H1N1 was the dominant influenza A subtype nationally. Now, the national trends do mask some regional differences. In this instance, influenza A activity started earlier in the prairie provinces than it did elsewhere in Canada and peaked earlier than elsewhere in Canada. As within Ontario, H1N1 was the dominant influenza subtype nationally. Influenza B activity had more of a similar pattern to Ontario, increasing starting in January through to a peak in the spring. It was maybe a little bit later on than for Ontario, as far as the peak was concerned. And RSV activity increased in October and had sustained activity through December of 2023 before declining. Moving along to look at respiratory virus activity internationally for the 2023-24 surveillance period. So oftentimes we look to Australia to see what's potentially happening in terms of their influenza season as a way of getting an idea of what may happen in Ontario in the upcoming season. So in 2024, the flu season in Australia seems to have started increasing at a similar time to the 2019 and 2023 seasons, as well as peaked around a similar time. However, the number of cases that were being reported was higher than in 2023 and remained higher for longer than in 2023. So moving to look at some COVID-19 activity in the United States and England, specifically because COVID-19 activity was increasing in Ontario over the course of the summer. So figured it would be interesting to see what was happening in some other similar countries. And you can see from these graphs on the left is the percent positivity for the United States, and you can see that increasing through the spring to a peak that occurred in the summer. And updated versions of this graph have shown that decline that you can see has continued. The graph on the right is the percent positivity for England, and as well, you can see percent positivity there increasing from the spring through to a peak that occurred in the summer before declining. Unlike the United States, there's been now a bit of an increase in COVID-19 activity again in England in in September. And in terms of RSV, RSV is actually a notifiable disease in Australia, and they present data for 2023 and 2024. And looking at those data, you can see that activity increased a few weeks earlier in 2024 than 2023 and peaked a few weeks earlier, but it didn't look too different. So now moving on to some considerations for the upcoming season. So what's the outlook for the 2024-25 surveillance period? I think one thing that we do expect is co-circulation of SARS-CoV-2, influenza, and RSV in the community. So we expect to see COVID-19 activity overlapping with flu activity and RSV activity. When they peak may happen at different times. Predicting when any of these viruses may peak, it is quite difficult and it is more challenging the earlier predictions are made. So going back to the sort of old adage of when you've seen one flu season, you've seen one flu season. Influenza activity in Australia, well, we look to it as a potential provider of information of what might happen in Ontario. It's not necessarily a reliable predictor of activity for flu in Canada based on an analysis that the Public Health Agency of Canada conducted. And that's available in the Canadian Communicable Disease Report, and the citation is at the bottom of this slide. As well, an evaluation of the U.S. Center for Disease Control and Prevention's flu site forecasting found the accuracy of the forecasts declined farther into the future that they extended. So a 1 week forecast was more accurate than a then a 2-week one, then a 3-week one, then a 4-week one. So at this point in time, currently, COVID-19 activity, it increased through the course of September based on trends that started in the 2023-24 surveillance period, and whether that increase ends up being sustained and continuing through the rest of October, or if it starts to decline is yet to be seen. And at this point in time, flu and RSV activity levels are low. Both have percent positivities under 1%. But that's why we produce a number of surveillance products in order to provide information on what's taking place in terms of respiratory virus activity. So that brings me to the discussion about PHO's Ontario Respiratory Virus Tool and the respiratory virus reports. So we do have an interactive data tool, the Ontario Respiratory Virus Tool, and I'll talk about that in more detail on the slide after this one. We also produce a number of static reports. The Integrated Respiratory Virus Risk Indicators for Ontario report contains projections for COVID-19, flu, and RSV activity for the upcoming 2 weeks. It's difficult to get accurate predictions farther out than that, so that provides a 2-week predictive or projection. We have the SARS-CoV-2 genomic surveillance in Ontario report, and that presents current and projected dominant SARS-CoV-2 variants data. That report is updated every week. And new last season, in the 2023-24 season, PHO produced an influenza surveillance, a genomic surveillance in Ontario report, which contained information on the circulating strains, vaccine match, and antiviral resistance data. The plans are to continue to produce that report in the upcoming season. As well, it was the first time PHO produced the respiratory syncytial virus genomic surveillance in Ontario report that contained information on circulating RSV lineages. And the plan is to refresh that report during the upcoming season as well. So the Ontario Respiratory Virus Tool, we update it every Friday at 11:30 a.m. That allows us time to receive all of the different data that we get and present in the tool, and to update it all at the same time. So it's not like one part of the tool is updated early and another part's updated afterwards. So to keep it all in line. There's a bunch of different sections in the tool. The summary tab does have a high-level summary of activity and trends. If you go to the trends tab there, you can see graphs that look back over the past 52 weeks and provide a quick look at the data and at activity in the province. We do present data in the lab testing tab on percent positivity, and that's more interactive. People can go through and look at percent positivity by health unit, by age groups where available. And then we have a tab that presents data on the number of respiratory infection outbreaks, including COVID-19 outbreaks in the province, by setting and by week. And we have an outcomes tab, which has information on the hospital bed census data, so bed occupancy for and with COVID-19 and flu, and with RSV. And that section also contains information on COVID-19 deaths. So last year was the first year that we had the Ontario Respiratory Virus Tool released. And in the spring, we conducted a survey of users. Based on feedback, there are updates that are coming to the tool that we thought it would be useful to make people aware of. So some things to look forward to we'll be including information on influenza subtype and strains within the summary tab of the tool. one of our static reports that presented information on outbreaks in long-term care homes and retirement homes is being transferred into the Ontario Respiratory Virus Tool. So it'll allow more interactivity and it won't be restricted to just showing outbreaks, that detailed information for COVID-19 flu and RSV outbreaks. You'll be able to look at attack rates and hospitalization rates and case fatality rates within outbreaks using that portion of the tool once it's updated. And we're incorporating some of the summary section of the Integrated Respiratory Virus Risk Indicators for Ontario report into the tool to show the 2-week activity projections for COVID-19 flu and RSV. We're adding in COVID-19 episode counts. These are not exactly cases. However, they're based off of positive laboratory tests with a little bit of logic applied to when they get counted. And they do align very closely with COVID-19 case counts previously. So those will be available, and more details on that on them will be available in the technical notes document. As well, we're going to be including Ontario Lab Information System testing data for influenza and RSV. That data is already available for COVID-19. It allows for people to look at percent positivity by health unit and by age groups as well, which is important to be able to do. And a bit of a plug for our updated technical notes that'll be coming out. These provide information on the different measures within the tool, how things are set up in the tool to help with interpretation of what people are seeing there. So while invasive group A streptococcal disease is not caused by a virus, it's caused by bacteria, it does, and you do see invasive group A strep cases throughout the year. It does tend to increase in the fall and winter at a similar time to when there's increased activity in respiratory viruses. For the past 2 seasons, 2022-23 and 2023-24, invasive group A strep activity has been well above expected compared to pre-pandemic levels. And so we wanted to make people aware, if they weren't already, of our regularly monthly updated reports on IGAS. And so the link for that's available here, and I believe in later on in our resources slide. So some updates that have come into place recently are the respiratory infection outbreaks in institutions and public hospitals outbreak definition has been updated. Those were posted earlier this week. The new definition does include COVID-19 outbreaks within it so that there's not standalone definitions there. The new definition is more specific. It has possible implications in terms of there being a potentially fewer number of outbreaks getting declared, and that'll be something to keep in mind when looking at outbreak data for this season compared to prior seasons. The current definitions that were just updated, they can be found on the Ontario Public Health Standards website under Appendix 1 of the Infectious Disease Protocol. And you can review the updated definitions there in more detail. And lastly, there are a few other resources that PHO has or will be updating on our website. One's a summary of the available vaccines for the 2024-25 flu season. This can be found on the influenza page on PHO's website, as well as an updated summary of considerations for the use of antivirals for prevention and treatment of influenza, which can also be found on the influenza webpage on PHO's website. We will be publishing our surveillance guide, which includes instructions for reporting and data entry in IFAS. In previous years, we did refer to this as our surveillance package. It's been delayed somewhat, but it will be getting released in the coming weeks. And at this point, I'd like to turn it over to Mon for him to go over COVID-19 and respiratory virus testing for the 2024-25 season.
Thanks, Michael. So in this section, we'll be discussing the COVID-19 and seasonal respiratory virus testing for the 2024-25 season at PHO. So as we know, like the respiratory virus testing will facilitate timely detection of respiratory viruses, and this will support early clinical intervention, including treatment guidance and infection prevention and control measures. Also, it will support the public health response strategies. And lastly is the surveillance component. So this will give you a snapshot of the respiratory illness trends and to assess the burden and program impact through covering trends over time, circulating viral strains, and geographical distributions by health units. So what does PHO offer for testing? There are multiple platforms. So there is a standalone SARS-CoV-2 for COVID-19 testing. There's another platform which covers the fluvid, which covers like 4 targets, including influenza A and B's, plus the SARS-CoV-2 and respiratory syncytial virus. The more expanded respiratory virus PCR panel, which is the multiplex panel, covers 11 targets, viral targets, and this including influenza, and it has the ability to distinguish even the seasonal influenza A strains, both the H3 and the H1 pandemic strain, plus the influenza B, together with the RSVs, parainfluenza, adenovirus, enterorhinovirus, seasonal human coronaviruses, and human metapneumoviruses. Some of these targets, viral targets, cannot be able to distinguish between the subtypes within that specific target. For example, for parainfluenza A, it's able to detect either of the 4 subtypes from 1 to 4, but it's not give you which specific subtype is contributing to that specific infection. The same is applicable also for the seasonal human coronavirus. And just to keep in mind that the seasonal human coronavirus is a completely different target than the SARS-CoV-2. We still, sometimes we get some questions about like confusion between those 2 viruses. And lastly is the rapid testing for influenza antigen. And this is offered only in outbreak settings and will be discussed in the coming slides. As I discussed earlier, testing provides support for outbreak investigations and control measures. So from last season, 2023-24, PHO supports outbreak investigations with respiratory virus testing. Around 4,100 outbreaks were investigated, and 42.8% they were positive for at least 1 target from the MRVP, and 11.1% had more than 1 target. For the COVID outbreak investigations, PHO supported 3,100 outbreaks, and 59% of those were detected for SARS-CoV-2. For the dual testing, both the SARS-CoV-2 and the seasonal respiratory virus, the PHO supported 2,900 outbreaks, and 85% of those, they were positive for at least 1 target, and 17% shared multiple targets, like minimum of 2 targets. And the highest percentage of like targets that were impacted from the MRV are the enterovirus, rhinovirus, followed by the human seasonal coronavirus, and then the parainfluenza. So for SARS-CoV-2 testing at PHO provide molecular testing. PHO does not offer any antigen rapid testing. However, antigen rapid testing the program is still available. There were new guidance released just 2 days ago. You can check the link here for the Ontario Ministry of Health for the testing guidance for COVID and treatment. And this will include also the rat antigen testing programs. So PHO aligned for testing eligibility for COVID testing, and this will cover individuals who are symptomatic, more than 65 years and over, or 18 years and above, who have high-risk medical illnesses that's prone to severe illness. Immune-compromised individuals also are eligible for testing. Apart from those, also people at in hospitals and congregate living settings, which are more like vulnerable, and any investigations and for outbreak control measures also are included in COVID testing. For more details, you can look into this link to provide you more information about the eligibility for testing and the test to treat for COVID-19. As we discussed earlier, the testing panel for respiratory viruses at PHO, it goes into two platforms, which is the multiplex respiratory virus, PCR, and the FluVid. If patient meets the testing criteria, which will come through it in the next slide, the submitted specimens will be tested for FluVid and or MRVP. COVID PCR also can be checked also on the same requisition and can be included also on the same collected specimen. So for the AMR multiplex respiratory virus PCR, the eligibility will cover symptomatic hospitalized patients, including ICUs, admitted patients, symptomatic children seen in the emergency departments under 18 years old, symptomatic residents in institutional settings, and this is cover the non-outbreak settings. And in an outbreak setting in within a hospital or any long-term care facility or nursing home, MRVP will be offered for the first 4 specimens within that specific outbreak. For the FluVid, this will include the symptomatic residents and healthcare workers and staff within an outbreak setting that are beyond the first 4, which were offered the MRVP. So anything beyond the 4 will be offered for FluVid, and this will help management of the outbreak or just finding any other viral targets that can be impacted and have a direct antiviral treatment. The final criteria for testing is symptomatic adults seen in emergency department whom are at risk for severe disease or outcome, and care for treatment and decision will be impacted by the test results. And this will ensure that the results will be available within the 24 to 48 hours since the specimen is received at PHO. As discussed in the outbreak setting, just to highlight again, the first 4 specimen of the outbreak will go for MRVP. Beyond the first 4 specimen, anything beyond that, it will be tested for FluVid. For rapid influenza testing, it is offered at PHO or regional sites at PHO. And this will be offered only when the molecular testing will delay more than 24 hours. And this can be applied in certain scenarios like in weekend or some remote settings where the molecular testing results can delay. So rapid antigen testing can be offered. At the same time, the specimens will be tested for confirmation for molecular testing. So the submitters will receive the results for the rapid antigen testing within 24 hours. Testing outside of the mentioned algorithm, PHO always happy to receive any consultation for adding more like requests, and this is under the discretion of the health unit, and we can discuss it case by case. For example, in certain outbreak investigations, sometimes we offer more MRVP testing beyond the first 4 if the scenario fits, and will help the management and control of that specific outbreak. So if any questions, just reach out to the customer service at PHO, and the numbers are available at the test information sheet. For requisitions of like specimens covering respiratory virus and COVID, please use the coronavirus and PCR test requisition. For other requisitions, use the general test requisition form. So asymptomatic testing is not recommended for COVID and other respiratory testing. However, in certain scenarios where outbreak is prolonged and for an unexpected transmission, despite fully controlled measures, at that scenarios, the submitters or the health unit can communicate with the PHO to permit testing for certain scenarios with asymptomatic testing. We know that those asymptomatic individuals are not be placed into additional precautions because there is a low test probability. However, it can be discussed case by case. So if the specimen was labeled as asymptomatic, this will be canceled by the default, and cancellation comment will be included in the report. And if you find that that specimen required to be retrieved and pulled, please communicate within appropriate time. We give like 5 days so that you can reach out back to the customer service to provide the indications for testing. Just would like to give you some submission guidance for the use of the requisition. So ensure that the COVID-19 and respiratory virus test requisition form is used. This form is available also for electronic orders for the use of like pharmacies. Ensure to include the 2 patient identifiers within the requisition, and they are labeled also within the specimen collection kit, and match which is what is written in the test requisition form. Ensure also to fill all the sections within the requisition, including which specific test is requested. So you have the option to choose a COVID-19 by itself or respiratory viruses, or you can choose the last one, which is a combination for both MRVP and COVID. Also, make sure to specify what type of specimen has been collected. Is it an MP swab? Is it saliva or throat nasal, or other specimens, including like, for example, BALs and sputums. Clinical informations are very important because, as we discussed earlier, if there are no clinical informations provided, we will assume that this is an asymptomatic setting and the specimen will be rejected with some cancellation comment. And the patient setting is also very crucial and important to be provided in the test requisition, because this will support us into selection which panel the specimen will go, either an MRVP or a fluvid, if it is an outbreak, or if it is a healthcare worker, or is it an inpatient. So ensure to include like all these information within the test requisition. For collection kits, make sure to check the expiry date prior to the collection. For both the collection swab and the media. Sample collected using the expired media will be rejected. If you use the Ontario Health, they provided some expansion for COVID testing. However, this is like limited only for COVID and respiratory viruses. It's not going to be applicable for other test requests, including like other viruses, like for example, HSV, Mpox, different viral targets. And ensure follow the same date, which is included in the expansion form for Ontario Health to be included in the acceptance criteria. As I discussed earlier, ensure that the collection swabs are labeled appropriately and the same two patient identifier, which are the same written in the test requisition. Samples that are not suitable for rapid testing will be sent directly for molecular testing. There are certain collection media which contain guanidine. It is not suitable for rapid influenza testing. So this will go directly to the molecular testing. For frequency and turnaround time, PHO will ensure that COVID and fluvid covering both COVID and influenza will be reported within 24 to 48 hours since the specimen received at the PHO. So it's an in-lab turnaround time. This will be impacted by some geographical location or proximity to PHO testing laboratories. The turnaround time for influenza rapid antigen, as I discussed earlier, we know that molecular testing is more sensitive, but in an outbreak settings where the molecular testing might delay beyond the 24 hours, so the antigen testing will be offered at that regional PHO lab, and results will be reported back to the submitters. The turnaround time for the rest of the MRVP targets beyond the COVID and influenza might take like a little bit more time, which is in our TIS is stated like up to 96 hours, although routinely like we can once the specimen received in the lab, usually within 72 hours, it will be released. The main purpose for the other respiratory targets is for the surveillance purposes to see like what type of other respiratory virus beyond the fluvid targets are being circulating in the province, including hospitalized, ERs, or even in an outbreak settings. PHO also offer other respiratory testing, and this will cover influenza, avian influenza, if there are any specific epilink to exposure to poultry, wild birds, or infected animals, or dairy cattle. We know that recently there were some circulation in the United States impacted by the H5N1 strain, highly pathogenic avian influenza. So testing is available at PHO. These needs to be communicated with the customer service prior to sending the specimen so that we will be aware that we are expecting the specimen. Antiviral resistance, if you suspect a patient with influenza not responding to treatment, you can send a requisition for antivirals, and this will support providing the results. Also, MERS-CoV-2 is available, which is Middle East Respiratory Syndrome coronavirus. If there are any certain exposure or some travel history to certain geographical area which are the virus is circulating, those will be eligible for testing. This also will require communication, plus the Entero D68 virus. All these viral targets require to be sent through the general test requisition. So it not to use the COVID-19 and respiratory test requisition, use the general test requisition. For the influenza surveillance, as Mike did mention, that we know that last year for the season 23-24, we had like a mixed pattern of like two seasonal strain were circulating, mainly H1, and then we start seeing H3. So sometimes it's hard to predict what type of like strain will be circulating like across this season. So PHO will offer support for influenza subtyping. with certain criteria, which will come into the next slide. And this will give us the ability to screen for any novel or influenza strain, because any influenza positive that will not be able to be captured through the H3 or the H1 will be further investigated for any novel influenza strain. And the influenza A subtyping criteria for this season applies to specimens that cannot be subtyped by primary testing laboratories. So we recommend the testing laboratories, if they have commercial kit for influenza, that are not able to distinguish between either H1 or H3, to send those to PHO for full subtyping. Specimens from cases suspected of animal to human transmission of influenza A virus, or specimen from patients with suspected influenza antiviral resistance. Also, from the surveillance perspective, we do subtyping and whole genome sequencing for those. Also, a patient admitted to the ICU with severe illness, those also will go into the subtyping and whole genome sequencing. I did mention about the enterovirus D68, just a small snapshot about this. This was addressed this year because it's an even year. We know that this virus circulates every other year. There was a spike of activity back in 2022, so we expect that this season also will be more of a heavy hit for this virus. So this is like one of the large group of the enterovirus. It can present with any acute respiratory illness. It might be severe enough to patient will be admitted to the ICU. There are some cases, reported cases related to acute flaccid paralysis, which is a reportable disease under the age of 16. So PHO do like random surveillance for this virus, and we started in July time, and we tested random selected enteropositive specimens at PHO. We tested 105, and we noticed 31 percentage of positivity since the mid of September. So we've seen activity of this virus. So just to keep it in mind, if you see any case of like a acute flaccid paralysis, we can test for D68 and do WGS and support the diagnosis. And last slide is just would like to give a snapshot of the Sentinel Practitioner Surveillance Network, which is the SPSN. So PHO do participate in this program within Ontario. So there are multiple jurisdictions, including British Columbia, Alberta, and Quebec, who participate in this program. And this is for primary care practitioners in the community to conduct surveillance and annual estimation of COVID and influenza vaccine effectiveness. So specimen collected from those individuals who present with acute respiratory illness or influenza-like illness within 7 days of onset, they will be swabbed and tested for both COVID and multiplex respiratory virus panel. There is a questionnaire also practitioners will fill for the immunization history against both influenza and COVID. And all these informations will be captured, and WGS also will be conducted with the support of the National Microbiology Lab at the Winnipeg to do the vaccine effectiveness studies. Results are shared via peer-reviewed publications. And this is a slide, as Mike did mention. It covers like different products, PHO products, including the Ontario Respiratory Virus Tools, some test requisitions form, any guidance, test information sheets for both COVID and respiratory, including influenza, can be looked into our website to have like full informations. And I can hand the slides now to Richard to do the acknowledgement.
Thanks, Mike and Mon, for your presentations. We will now move on to the Q&A segment of this event to address some of the questions from the audience. Please continue to enter your questions into the Q&A pod regarding the topic of today's presentation if you have not already had the opportunity to do so. And please keep in mind that the second part of the respiratory season presentation series will happen on October 10th, and then any questions on vaccines can be answered during that time. To start with, there were a few questions about sharing the link to the new case and outbreak definitions, so I have put that into the chat now. First question, I think this one would be for Mike. Can you speak to any factors leading to the decline of cases of COVID-19 in March of this year?
Thanks, Richard. So I think when you look at the epi curve for it in terms of the percent positivity, you ended up having a peak in November. That would have been after vaccination campaigns were started and ongoing last winter. So I think those combined with the just people having acquired infections and then having an acquired immunity afterwards, population level immunity got high enough for COVID-19 activity to decline until March, at which point there's enough waning immunity that you can start to see an increase in activity again afterwards. That'd be my thoughts on that question.
Great, thank you. For the next question, with the move to aggregate reporting of influenza cases by health units, how will this data be utilized by Public Health Ontario?
Okay, so I can take that one. So influenza case data, we use it in calculating activity levels for influenza. We use that information for reporting to the Public Health Agency of Canada for activity levels as well. So we'll be using those data for those purposes. They'll also be included in the Ontario Respiratory Virus Tool in terms of the number of flu cases that are occurring in the province, and by health unit, those will still be available for people to view in the tool. Yeah.
Thank you. Next question, will there be any COVID-19 wastewater surveillance done in Ontario this year by Public Health Agency of Canada or PHO or anyone else?
So I think I can take this one in terms of current wastewater surveillance testing. The Public Health Agency of Canada is doing wastewater testing at 4 sites in the city of Toronto. The data are available on the Canada Health info base. We can put that link in the chat. In terms of, I think I saw some other questions about the expansion for wastewater testing. As far as I understand it, discussions are still ongoing. So it remains right now at the 4 sites. In terms of what PHO presents in the Ontario Respiratory Virus Tool, because it's only 4 sites at this time, we haven't incorporated the wastewater surveillance data into the tool since it's only for Toronto. But once the expanded sites are available, as I think was announced over the summer that's the plan, then we would consider including that information in the tool.
Great, thank you. Next question is about ordering tests. Can specimens be sent to PHO for suspected outbreaks, or is it only for confirmed outbreaks? That would be for Mon.
Yeah, so any symptomatic individual, for example, in long-term care facilities, is eligible for COVID and MRVP. But if there is like declaration of an outbreak, the lab will accept the first 4 of those specimens, and this will support identification of the specific viral target within that outbreak.
All right, thank you. Next question is, any recommendations or guidance for smaller congregate settings who do not have medical professionals who can provide medical directives for testing of residents. I'm not sure, Aman, if this is a type of question that you ever get, or should I like me to answer this one?
So usually, as I did provide in the presentation, the slide, so there's a new guidance that was released on October 1st for COVID-19 testing and treatment. And this will include like who's eligible for testing and how to, there's a specific section also for rapid antigen and how to order those kits and which portal you'll use. So definitely you can find like all these informations and for those specific settings.
Great, thank you. Next question. In the past, influenza activity was not seen when COVID activity was high, and it looks like from the graph on slide 37 that there could be co-infections with both viruses. Is this a change that has been seen? I guess, are we seeing more co-infections of influenza and SARS-CoV-2?
I think it's hard to see it in the data sets that we have available to us. I think the question would be maybe whether MON in the PHO lab testing, when the flu-vid tests are performed, are there a lot where it's back positive for flu and COVID on those?
Not sure if Mon's had technical issues there. I think one particular potential reason why we may be seeing more co-infections of influenza COVID-19 is just the increased utilization of the flu-vid testing. So individuals are being tested for both viruses, where in the past people may not have been tested for both at the same time. But not sure if Mon has anything else to add on to that.
No, I agree with you both, Mike. And so if you have any specific targets, especially for flu-vid, where antiviral treatment can be applied, so this will be useful. Beyond that, for like if there is an outbreak setting, like infection control practices will be applicable the same if there's another target. But if there is a specific scenario with like prolonged like outbreak with appropriate control measures, definitely PHO will be supportive testing like extra targets with extra specimens from beyond the eligible criteria and numbers that's been provided in the test information sheet.
Great, thank you. Next question. For those who have access to rapid antigen tests, are they still a reliable way of diagnosing COVID-19?
So we know that rapid antigen test, it has like a lower sensitivity. However, it will be more of use when there is an outbreak setting because the test probability will be high, positive predictive value will be higher in an outbreak settings. So it can be of value, especially when there are remote settings. However, we do encourage if the option to send a molecular testing, and especially the results can be provided within 24 to 48 hours, which will support the outbreak management. Molecular testing is more sensitive because you could have like a false negative rapid antigen testing. And for supply, it's all, as I discussed earlier, it's all been through the PPE supply, Ontario, and you can have like all the guidance for that and within the recent document that has been shared 2 days ago.
Great, thank you. For the next question, in an outbreak setting in a long-term care home, after the initial 4 swabs have been sent and the pathogen has been identified, is it mandatory to continue sending swabs for flu-vid panels, or is further swabbing unnecessary for additional cases?
Yeah, we start getting some questions about those. So we offer the flu-vid because you could have like a mixed infection in certain outbreak settings. And we offer the flu-vid because you could have like an parainfluenza virus, but could be a co-infection with the COVID or influenza where you can have like a specific directed antiviral treatment that can improve, especially with vulnerable patients who are at risk of severe illness with either COVID or influenza. So if you feel that the patient is worsening or the outbreak is not well controlled, so definitely Fluvid is offered beyond the first 4.
Thank you. The question just disappeared on me here. The question was about turnaround time for swabs in outbreak settings. Just a clarification of the turnaround time for MRVP and Fluvid, and when the rapid influenza tests would be performed.
Yeah, so so this is one of the reasons we recommend that you include the outbreak number in the requisitions, so that the lab will be aware that this is specimen is specific for an outbreak investigation. Those specimens will be pulled like earlier and can be tested and provide the result within 24 to 48 hours since the specimen is registered at PHO. So there's a transit time which is beyond our hands. Unfortunately, we cannot control that. But we try to ensure that the Fluvid portion of the MRVP will be provided so that you can apply any directed antiviral treatment and control management.
Thank
And
you.
for the rapid antigen, as I discussed it also on the slide, in scenarios, for example, during weekends or certain regional labs where they don't offer molecular testing and they have to ship it to another regional site, PHO site. So those sites will have the leisure to do the rapid antigen testing if the molecular testing will delay more than 24 hours. So the influenza rapid testing will be offered during that specific time and will be the results will be released within 24 hours.
Thank you. Next question is there an expiry date for PCR swabs or just for culture medium?
So so usually they label them. Each kit will come with an expire date. We don't accept like expired media unless if it falls into the designated batches that fall into Ontario Health like expansion, because PHO did support validation for COVID testing. We expanded this validation to cover the MRVP and the Fluvid, and it will be limited to the that specific time frame. I remember it was the most recent expansion was back in early of 2024, and it covers around like 500 days. So if it falls into that specific time, it will be accepted only for MRVP, COVID, and Fluvid. Beyond that, any viral targets beyond that, it will not be accepted. It will be rejected. For example, measles, HSV, VZV, any other viral targets.
Thank you. Next question is about ordering tests during an outbreak. Should test requisitions be sent on paper that is not white during an outbreak?
Sorry, Richard, I didn't. Not
so,
white.
Yeah, so I'd heard at times to send in a test requisition on a different color sheet or put say a piece of green paper in the bag to help flag it when the samples arrive.
It's preferable if you can do the flagging. That will be easy detection for the front end processing at the lab, but it will be an asset if you can add that.
All right, thank you. So the requisition itself doesn't have to, can be white, but just put another piece of paper in the bag that's colored to help flag it?
Correct.
Okay, thanks. Question about the new outbreak definitions. Says, must there only be one causative agent per outbreak?
So I think the intention of the updated definitions is that all of the cases that are part of the outbreak will have the same organism, so that if you have positive flu cases and then say other people who are symptomatic who test positive for RSV, that's sort of a concurrent flu and potentially concurrent RSV outbreak. It's something that we can take back to clarify with the ministry as well. We'll be working through updates in our data entry guide for IFAS in terms of how to report those. And so that's underway as well. We're taking a look at it again in light of the updated outbreak definitions that have come out.
Thank you. A question about people receiving expired universal transport media and the extension of the expiry dates. Just to confirm if these will be accepted by PHO Labs. This is one you already answered, Mon.
Yeah, if they fall into that specific time frame, it will be accepted. Beyond that time, it's not going to be. It's going to be rejected, and the cancellation comment will be included in the report.
All right, thank you. Next question is about timing of influenza peaks, and is there any relation between temperature and humidity values? Why we see influenza peaks in the winter time?
I think that it's something that people have been discussing, and partly it also can come down to people being inside more than, say, in the summer. I would have to go and revisit the literature on, transmission through droplets and whether flu likes that better or not. But you can see in the trends that the flu clearly peaks at a colder, potentially drier time than in the summer when it's nice and warm and humid. And so there's the correlation there.
Thank you. Next question about surveillance. So when there is less testing done, how accurate is surveillance?
Thanks for the question. I think that in the situation that we have with the percent positivity data that we look at, we were able to look at that as well as across other measures to try to keep a handle on what's going on with respect to activity. As an epidemiologist, like more data is always better, but we do look at multiple indicators to try to build a picture of what's taking place.
Thank you. Question about enterovirus in long-term care homes. Is further testing being done on all cases to determine the type, such as D68? And is that information available?
Yeah, thanks. That's a good question. It's not necessarily, because we know that D68 is not reportable by itself unless if you have an acute flaccid paralysis under 16 years old. This is like a reportable disease. We know that enterovirus is one of the commonest virus, and we know, and from the slide presented from last season, it's like 15% of the outbreak investigated within the MRVP, they were positive, which is the highest percentage. So there is no mandate of doing further investigation as long as you know that this is an enterovirus. But if you suspect that there is an acute flaccid paralysis in that specific outbreak or setting, or that this is an enterovirus circulating, at that scenario you can call the lab and ask for further testing. And we do report the randomly selected specimens, we do report them back to the submitters just for the surveillance purposes. It's not for the a purpose of notification or reporting.
Thank you. Next question. Can you confirm that a primary care physician can request a COVID test on someone who is eligible for treatment, such as an individual over the age of 65?
Yeah, so that fits into the criteria for COVID testing. So as long as the information is written in the test requisition, definitely this will be accepted for COVID, but not for other respiratory viruses. from an outpatient setting.
All right, thank you. Question about RSV activity. RSV activity appeared to be a bit higher in Australia this year compared to last year. And do you think we'll have an increased RSV activity in Ontario this year?
It is kind of hard to say. I mean, Australia does give sort of a bit of a advanced look, but might not always be predictive. I think one of the things to keep in mind is that at least in Ontario, the past 2 seasons have been early, so that's something we'll be keeping an eye out for right now. In terms of how much there ends up being, I think it's sort of anyone's guess at this point because there really isn't very much RSV activity taking place right now, so it's hard to know. I would encourage people to look at the respiratory virus tool as well as the integrated respiratory virus risk indicators report. That report also does include information on severity, so in terms of hospital bed occupancy, so to be able to get an idea of how the season's going as it unfolds. But right now it's pretty hard because there's just not much activity here.
Thank you. Next question is about testing of asymptomatic patients. Would PHO accept specimens from asymptomatic patients who were transferred from an outbreak facility to another hospital?
With the recent guidance, it's not included in that guidance. So any asymptomatic individual specimens will be rejected and released with a cancellation comment.
Thank you. Any recommendations for testing for symptomatic individuals in a primary care setting? Should these individuals be tested with PCR or rapid test?
So we know that PCR is more sensitive for COVID, for all like viral target, but for outpatient setting, we know that it's only applicable for COVID. So individuals above 65 or 18 years old and above with our risk factor for severe disease, those will be eligible as long as the information is stated within the requisition. Pharmacies also can provide like a submission through pharmacies. So PHO will support testing through those modalities.
Thank you. Next question is about timing of influenza A and influenza B peaks. Do we know why we see different peaks of the two influenza A viruses and why we see influenza A peak before influenza B?
It's a good question. Off the top of my head, I can't recall the reason for that, other than it does happen to be the sort of order of when flu activity occurs.
All right, thank you. Next question about ordering rapid tests. Do they need to be requested by health units, or is this something that PHO would do automatically to send out test kits?
Yeah, thanks. So PHO is not involved like with the rapid antigen test program. You can visit the link and the website through the recent document that's released, and through the PPE supply. If you're eligible for that, it can be offered with the guidance written in the website.
Thank you. Next question about fluvid and MRVP testing. Does PHO perform these over the weekend or only during the work week?
Yeah, so we do perform them during the weekend. Some regional labs, including I think Toronto, is mainly Toronto, they offer the testing 7 days a week, so including Sunday. Other regional sites, they do testing Saturdays, but not Sundays. But we do like collaborate together if there's like any like if you feel that this is like an outbreak investigation and you need like results during a weekend, please ensure that you collect those specimens prior to that like like end of Friday, Saturday, or maybe you ship them directly to Toronto sites because we have testing throughout the week, the weekend, Sunday and Saturday.
Thank
The information is all available in the test information sheet, which labs are testing, and usually we go through the across the season, like if we see any requirement of changing our algorithm with testing, this will be updated in the TIS, and information will be provided to the health units and clients.
Thank you. Regarding testing of staff in long-term care homes, are symptomatic staff eligible for PCR testing?
Symptomatic staff are eligible if an outbreak is declared for only flu-vid, which would be attributed to part of like the control measures for the outbreak. But prior for declaration of an outbreak is only the residents will be eligible for the MRVP.
All right, thank you. Another question about testing. If a staff reports testing positive on a rapid antigen test, should a PCR test also be performed?
If the clinical symptoms and the epilink and the rapid and during the high peak of the season, we know that the positive predictive value of the rapid antigen will be higher during these stages, so it will be sufficient. You don't need to further test molecular test. It's further sent for molecular testing.
Thanks. And a follow-up question about ordering influenza rapid tests. So the question is, if there is a delay in molecular testing, will PHO automatically do the rapid influenza testing?
Yeah, correct. So all regional labs at PHO, they have the ability to test rapid influenza tests. So if there's any delay for any reason, it's going to be tested by default, if it is part of an outbreak investigation.
Right, thank you. Question about COVID-19 activity. Has COVID-19 activity peaked in Ontario, or is it still continuing to increase? And do we anticipate that Ontario trends would typically follow trends in other jurisdictions, such as the US, where activity is already peaking?
Yeah, it's a good question. I think it doesn't necessarily follow exactly in other jurisdictions, like the way that their COVID-19 activity is taking place. In terms of whether or not we've peaked or not, we've had an increase that took place all the way through September. It's looking like from the data that will end up being in the ORVT tomorrow that there's been a decline for 1 week in activity. That doesn't quite make a trend. We'll need to see a few more weeks to know whether or not that's true or not. We've seen declines before that can take place over a week or two, and then it goes back to the same sort of increasing trend that had been sort of the longer term trend. So we'll be keeping an eye on it. It would be interesting if it did peak sooner, because then it would have shifted the peak earlier from when it occurred last year. And you know, we still don't have like a great pattern for COVID-19 activity in the province. It seems to move around a little bit, but we've only been a couple of years since the public health measures that were in place during the pandemic were sort of rolled back. And so with sort of more general community mixing taking place and everything, it's that there's still not quite a predictable pattern set up, like say for influenza, where you can kind of tend to know it's going to happen in the winter. When exactly is the question, but for the COVID-19 activity, it's not like that yet.
All right, thank you. One last question. It was mentioned earlier that the number of new outbreaks may go down with the change of outbreak definitions. Why would that be?
Yeah, so it's possible because the outbreak definitions are more specific. They require more cases to be laboratory confirmed before the outbreak is declared, or more cases in general. Um, and so it's possible that there could end up being fewer outbreaks declared in the first place as well. I think the inclusion of the sentence about all of the cases within the outbreak should have just the one organism. In some instances, that may increase the number of outbreaks that get created in the system. You'd have like a flu and an RSV outbreak, where before it would have been combined. But on the whole, like the smaller outbreaks where they were like a couple of cases. One of them has a lab confirmation for flu, and the other one or the other two don't have confirmation. Those wouldn't meet the new definition for an outbreak. So that's why it could go down. I think it's something we're gonna be looking at when we're watching the data.
Great, thank you. As we wrap up today's PHO rounds, I'd like to thank Mike and Mon for their great presentations, and I'd like to thank everyone who joined us for today's rounds presentation. You can expect to receive a brief and anonymous PHO round survey for today's session. Please try to complete this to help us improve our programming. Lastly, to access past PHO presentations and to view confirmed and upcoming sessions, please visit the PHO website, head to Education Events, and click on Presentations. Thank you and have a wonderful day.